Hello everyone and welcome to a new session of clinical pharmacology, and the unit we are talking about is like cardiovascular clinical pharmacology. Today we are going to speak about antiarrhythmic drugs. In this session today we are going to focus on the cardiac conducting system, normal sinus rhythm, cardiac action potential, causes of cardiac arrhythmias, and the classification of antiarrhythmic drugs. We are going to focus on each group of medication, on the mechanism of action, clinical indication or like clinical uses of each group of medication, adverse drug reaction, and at the end we discuss some contraindication of these medication. Speaking about the conducting system and normal sinus rhythm, we know that the heart rhythm is determined by the SA node, sinus atrial node, which is called cardiac pacemaker. And this cardiac pacemaker is responsible for the sinus rhythm. This sinus rhythm is like a kind of specialized pacemaker cells that spontaneously generate action potential. Action potential spread through the conducting system pathway, and the normal sinus rate between 60 to 100 beats per minute. So the heart rate rhythm between 60 to 100 beats per minute. If you have the heart rate less than 60, we call this one bradycardia. If the heart rate above 100, we call this one tachycardia. So we have a normal sinus rhythm between 60 and 100. Above 100, we call it tachycardia. Less than 60, we call this one bradycardia. Speaking about cardiac action potential, we have 5 phases. Start with phase 4 that demonstrate by the action potential depolarize the cells and to the threshold to minus 70 millivolts, followed by phase 0, which mean the rapid depolarization, and this is caused by a transient opening of fast sodium channels. So in the phase 0, we have a sodium channel will be open, and this will cause depolarization due to the increased entry of calcium into the cells and cause depolarization. Phase 1 maybe demonstrate by initial repolarization, and this will maybe associated with the opening potassium channels in phase 1. And we have during this phase we can see some slow inward of calcium at the same time, but it's not like the real amount of calcium. We still have slow amount of calcium enter the cells. Okay, in the phase 2, we have the plateau phase. The plateau phase, here we have potassium will enter the cells in more concentration, and followed by phase 3. Phase 3, potassium channel will be open, and you can see the phase 3 associated with the repolarization. Potassium channel will be open, on the other hand, the calcium channel will be inactivated. Okay, I'm sharing with you this picture from the Wikipedia, as you can see here, and this picture here maybe demonstrate the action potential for the heart, and you can see phase 4, then phase 0, phase 1, 2, 3, and 4. You can see in phase 0 the sodium will enter the cell and cause depolarization. You can see the action potential moving maybe to the we call this one upstroke. Then we followed by phase 1, kind of repolarization. Potassium channel will be open here. Potassium channel allow potassium to leave the cells. Then we move to the phase 2. Phase 2, calcium will be predominate. Calcium start entering the cells and cause plateau. Is kind of balance between calcium and potassium. Okay, what happened there? The calcium channel will be closed in phase 3. So closing calcium channels, at the same time a lot of amount of potassium will leaving the cells and cause hyperpolarization. So you can see hyperpolarization in phase 3. So if you compare phase 3 with maybe versus phase The 0 here, you can see phase 0 associated with the depolarization, rapid depolarization due to the entry of sodium. On the other hand, phase 3 associated with the outflow of potassium out from the cells, and this will lead to the hyperpolarization. In phase 4 again is like a kind of bring the case to the normal rest, normal physiological action. Here we have movement between sodium, calcium, and potassium, and we have sodium potassium ATPase pump here in this phase. Okay, speaking about the causes of cardiac arrhythmia, as you can see here, cardiac ischemia, one of the most important maybe or important causes of cardiac arrhythmia. This could be related to the angina, or could be related to the myocardial infarction. So cardiac ischemia, the same will be applied here. For example, for cardiac hypoxia, increased preload and afterload of the heart. If you have any maybe disease related to the heart muscles, or related to the valves, or related to the hypertension, for example, when you have hypertension, or you have something like cardiac disease related to the increased preload and afterload. Metabolic acidosis, metabolic alkalosis, another cause of cardiac arrhythmias. Electrolyte abnormalities such as hypernatremia, hyperglycemia, hyperkalemia, excessive catecholamine exposure. Here we have a lot of, in this case we are going to have a lot of epinephrine and norepinephrine. Okay, autonomic influences. This is the important one here. If the patient suffer from drug toxicity such as digitalis or antiarrhythmic drugs or sympathomimetics, could lead to the cardiac arrhythmias. And at the end we have genetic. We have some people have genetic predisposing factors lead to the cardiac arrhythmia. Okay, the next section here present the category or classification of antiarrhythmic drugs. As you can see in this section here, antiarrhythmic drugs, we have class one. Then we have class 1. Then we have class 2, class 3, and we have class 4, and then we have other. Talking about class 1, the class 1 block sodium channel. Class 2 belong to the beta blockers. Class 3 potassium channel blocker, and class 4 calcium channel blocker. For the other, we have digoxin, we have adenosine, and we have atropine. Okay, so the question now, which one is like related to the class 1, sodium channel, beta blocker, potassium channel, or calcium channel blocker? The answer will be sodium channel blocker. Which one belong to the class 2? It will be beta blocker. Which of the following medication belong to the which of the following maybe class include potassium channels? It's class 3. Okay, we need to be familiar with this category of medication. Now we try to remember. We have 4 main category here. Again, for number 1, we have sodium. Then we have beta blocker. Then we have potassium blocker. Then we have CCB. And we have other. So this is a category for cardiac arrhythmias. Class 1, they divide the class 1 in 3 subcategory. Class 1A, class 1B, 1C. What happened there? For 1A, we consider like intermediate active, intermediate efficacy or potency. So you can see here for sodium channel intermediate, we have 3 medication: disoberamide, quinidine, brocanamide. 3 medication, disoberamide, quinidine, brocanamide, belong to the class A. Then moving to the class B. For class B, we have 2 medication, maybe we have more, lidocaine and mexiletine for class B. And the class 1B considered like weak sodium channel blockers. Moving to the class 1C, class 1C considered the strongest. So as you can see here for 1AB, 1A, 1B, 1C, we can look on this medication according to the Potency. Which one is like more potent? 1C. Which one intermediate? 1A. Which one is like weak? 1B. So mexilitine belong to the 1B. Lidocaine belong to the 1B. Okay. So 1B, we have two medication, lidocaine, mexilitine. For 1C, we have flecainide and propafenone. So for this one here, we have maybe some mnemonic. We are going to practice that in the next slide. We have some mnemonic for the class 1A, 1B, 1C. For example, when someone go to the McDonald's to order food, they ask for example double quarter pounder. They ask for lettuce and mayo and fries, please. So we have this mnemonic here: double quarter pounder 1A, the disoberamide, quinidine, procainamide. 1B, lidocaine, mexilitine, and flecainide and propafenone for 1C. The question: which one of these class 1 will be the most potent or the strongest? Class 1C include flecainide, propafenone. Class 1A we have considered like intermediate, and the weak maybe for this group of medication will be 1B, lidocaine and mexilitine. Okay, regarding the beta blocker for the class 2, we have ismilol, metoprolol, propranolol, acetolol. Moving to the potassium channel blocker class 3, we have amiodarone, dofetilide, dronadirone, butylide, sotalol. And we have calcium channel blocker, two medication in calcium channel blocker. We have diltiazem and we have verapamil. For the other, we have the three medication is already covered. Okay, moving to the, we start speaking about briefly about each group of medication. 1A, we have double quarter pounder, we have disoberamide, quinidine, procainamide. This medication blocks sodium channel, prevents sodium influx, and this will slow rapid upstroke during phase 0. And also this group of medication inhibit calcium and potassium channels. This is like secondary action. So the main action of a class 1A to block sodium channel, but we have secondary action by blocking calcium and potassium. This medication lead to the prolonged QRS. This medication, group 1A, disoberamide, quinidine, procainamide, used for atrial fibrillation, atrial flutter, and ventricular tachycardia. Okay, for class 1A also, we need to look on some medication available here. You can see the procainamide available injection. That means we use it for the acute atrial fibrillation or ventricular arrhythmia. Procainamide, intravenous formulation, procainamide. But we don't. It's not considered like first line choice. We go with the amiodarone or like electrical cardiovascular or cardioversion defibrillation. So we go with the alternative option here, electrical cardioversion or defibrillation, and amiodarone is like the most replaced approach here. We don't recommend to go the procainamide. So we have option procainamide could be the second or third option for the cardiac arrhythmias. The first option will be defibrillation. Disoberamide used for the control atrial fibrillation and flutter. What about quinidine or quinidine? Quinidine not only blocks sodium channels, they found quinidine also has alpha adrenergic blocking activity. Quinidine has anticholinergic action. So quinidine has some atropine action. So what we have here, we have two actions carried with the quinidine. Quinidine not only sodium blocker, quinidine also sodium blocker, alpha blocker, and atropine-like action. So three actions may be associated with the atropine: alpha adrenergic blocker, anticholinergic blocker, sodium channel blocker. Okay, so what happened here? In this group of medication, what about the other medication? Disoberamide, procainamide. They said disoberamide and procainamide has neither or nor has activity on by blocking alpha. So the disopramide, procainamide does not maybe inhibit alpha receptor. On the other hand, disopramide has more anticholinergic activity. Here we're talking about atropine-like disopramide. And we have the disopramide. It's available as capsule, disopramide. Procainamide, so IV, less anticholinergic action. So 1A, we cover 1A. Okay. Common side effects, yes, this medication has a negative inotropic on the heart. That means negative, inotropic mean contraction. When you say inotropic, we talk about heart contraction here. And when you say negative, decreased contraction of the heart, in this case, if the patient suffers from heart failure, this medication worsens heart failure symptoms. Okay, the patient on quinidine may suffer from the quinidine toxicity. We call this one synchronism, associated with nausea, vomiting, diarrhea, blurred vision, tinnitus, headache, disorientation, and psychosis. So which of the following medication associated with the synchronism during treatment of cardiac arrhythmia? Quinidine. Okay, moving to the procainamide. Procainamide may cause hypotension. Procainamide given IV, as we mentioned already. With the chronic use, procainamide may cause lupus-like syndrome. Okay, we have some picture for lupus-like syndrome here. So you can see the lupus-like syndrome, the skin rash on the face and on the cheeks and nose for lupus-like syndrome. And this could be related to several medication for lupus-like syndrome here. Another maybe beige, I will share it with you. You can see the beige here. We have some other medication maybe engaged or involved or responsible for lupus-like syndrome. Drug-induced lupus-like syndrome, drug-induced lupus erythematosus, isoniazid, diltiazem, procainamide, minocycline, and quinidine. So we have list of medication may cause lupus-like syndrome. Okay, the last one, disopramide. If you remember, disopramide has strong effect on the anticholinergic. The patient may suffer from dry mouth, urinary retention, blurred vision, constipation. Here, if you apply the atropine, if you remember the atropine action, in this case, you are going to remember these effects. So disopramide associated with the atropine action, dry mouth, urinary retention, blurred vision, and constipation. Okay, moving to then the second group in the class 1. Class 1B now. We cover class 1A by talking about the disopramide, quinidine, procainamide. Class 1B, we have two medication. We have more, but this is a most popular medication in the class 1B. We have lidocaine, then we have mexiletine. Lidocaine, they said both of these drugs does not, maybe neither the drugs contribute to the negative inotropic. So 1B, there is no effect on inotropic. Okay. So what we have here for lidocaine is like we can use lidocaine for patients who are from ventricular fibrillation or from ventricular tachycardia. So it could be used lidocaine IV. We use lidocaine IV for the patients who are from ventricular fibrillation or from ventricular tachycardia. However, amiodarone remains the drug of choice. So the first option will be amiodarone for the ventricular fibrillation and ventricular tachycardia. The alternative option will be lidocaine IV. Also, we can use lidocaine with amiodarone for patients who are from ventricular tachycardia storm. That means we are talking here about severe maybe symptoms related to the ventricular tachycardia. Mexiletine in this group, mexiletine prescribed orally, indicated for chronic treatment of ventricular arrhythmia. So 1B mainly cover the ventricular muscles or the ventricle arrhythmias. Lidocaine, mexiletine. We use lidocaine when we have emergency case or like case need to the approach immediate with an immediate need to maybe to control the cardiac arrhythmia, lidocaine drug of choice. Mexiletine, for example, if the patient discharged from the hospital, we can place the patient on mexiletine as a chronic treatment for ventricular for ventricular arrhythmias. Okay, side effect. So what we need you to remember for the side effect here, they said lidocaine has wide therapeutic index. Okay, and on the other hand, you can see we have different color here. Mexiletine has narrow therapeutic index. So we already covered that in the pharmacodynamic. When you talk about wide therapeutic index, here we have the maybe this is a toxic effect here. Toxic effect here, subtherapeutic effect. Here we call this one therapeutic window or therapeutic index. So what we have here, they said lidocaine has wide therapeutic index. That means we have the possibility to move the dose up and down without risk of toxicity. We have large windows. On the other hand, mexiletine present narrow therapeutic index. So if you talk about mexiletine, for example, here, the therapeutic window will be smaller, like this one here. So any change in the plasma concentration will lead to the toxicity. So the mexiletine associated with the narrow therapeutic window, and at the same time, patient may suffer from nausea, vomiting, and dyspepsia. Okay, moving to the third group in class 1, we have class 1C, two medication as it's shown on this slide. We have flecainide and propafenone. Flecainide available like 50 milligram orally, given every 12 hours. Propafenone immediate release and prescribed orally also. And they said propafenone has weak blocking effect, blocking properties, and both of them slow AV conduction. We use this medication, flecainide, for patients suffer from atrial fibrillation, atrial flutter, and supraventricular tachycardia. So if you remember, I will go back a little bit. If you remember class 1B, mainly used for patients suffer from ventricular arrhythmia. However, class 1C we use for the atrial fibrillation, atrial flutter, and anything above the ventricle. We're talking about the supraventricular. Here, the most important things about this group of medication, they said, for the group of medication, propafenone may cause bronchospasm. So if the patient suffers from asthma, we don't recommend to prescribe this medication. For example, you are going to have case study. Patient arrived to the hospital, to the emergency department. This patient has history of asthma, but the current situation will be atrial fibrillation. Which medication it's not allowed to prescribe to this patient? So propafenone is not allowed to prescribe to the asthmatic patient due to the risk of bronchospasm. Okay, we have some medication here, propafenone. You can see it here. We have several doses like 325, 425. Speaking about flecainide, we have 50 milligram. It's available as a tablet. Okay, so we're done with that three group of medication. I would like to share with you maybe a screen on website on CV pharmacology. The purpose of this slide here, and this only to give a credit to the channel CV pharmacology. So what we have here, they demonstrate the action potential, for example, effective refractory ARB, effective refractory potential. We discuss phase 4, 0, 1, 2, 3, and 4 with you. Then we move to this is the purpose of this. Maybe it's looking on this website here. As you can see, we have 1A, 1B, 1C. You can see the 1C, the most effective group of medication, the most effective 1C. Okay, the strong, You can see 1C, the strong, and then followed by 1A, considered like the moderate. Then we have 1B, considered like the weak. So we have three group of medication belong to the class 1, while 1A, B, and C. Class C will be the strongest. Okay, moving to the class 2 antiarrhythmic drugs, we have beta adrenergic antagonist, or we call this one beta blockers. This medication prolong AV conduction, decrease heart rate, decrease contractility. This medication could be used for patients suffer from tachyarrhythmia caused by increased sympathetic activity, such as patients suffer from thyrotoxicosis. Thyrotoxicosis mean patients suffer from hyperthyroidism, which associated with the increased level of T4, T3, and decreased TSH. So this is a case for hyperthyroidism here. So if the patient suffers from hyperthyroidism, this will be associated with the tachyarrhythmia. We can use beta blockers such as propranolol, atenolol. You can see here we have some medication: metoprolol, sotalol, ismolol. We can use it for atrial flutter and atrial fibrillation. We can use it to prevent life-threatening ventricular arrhythmia followed by myocardial infarction. So when the patient come to the hospital emergency room, suffer from myocardial infarction, and the patient discharged from the hospital, we can place the patient on beta blocker to maybe prevent life-threatening ventricular arrhythmias. Metoprolol, you remember that metoprolol considered like beta 1 blocker, metoprolol, beta 1 blockers, and used for cardiac arrhythmias. For these three cases here, tachyarrhythmia, atrial flutter, fibrillation, prevent life-threatening ventricular arrhythmia followed by myocardial infarction. Sotalol, non-selective beta blocker, considered like class 3, sotalol, block potassium channel. So sotalol belong to the beta blocker and belong to the potassium blocker. Okay, ismolol. We have some important advantage or characteristic of ismolol. Ismolol has very short half-life, fast acting, and used IV for patients suffer from acute arrhythmias and emergency room. Ismolol will be metabolized in the plasma by the red blood cells. We have enzyme, and this enzyme responsible for metabolism of ismolol. This enzyme called esterase. So we have enzyme inside the red blood cells responsible for metabolism of ismolol. Okay, so we discussed class 1, class 2 belong to the beta blocker, and then we move to the class 3. We have potassium channel blocker, and that include the main medication, drug, the main drug, amiodarone or cordarone, the most commonly antiarrhythmic drugs, the most commonly prescribed antiarrhythmic drugs. This is the important things. What is the most commonly prescribed antiarrhythmic drugs? Amiodarone, cordarone. Amiodarone not only blocks potassium channel. Amiodarone not only blocks potassium channel. They found amiodarone blocks sodium channel. Amiodarone has beta blocker activity. Amiodarone block potassium channel. Amiodarone antagonize calcium channel and cause vasodilation. So you can see here amiodarone affect potassium, affect sodium channel, affect calcium channels, and beta blocker activity, in addition to the vasodilation. Okay, so we consider amiodarone the most effective medication, most commonly used, but it has a lot of adverse drug reactions. So we have some advantage, disadvantage. Advantage, most commonly used, most effective medication for cardiac arrhythmia, but this medication associated with the with the adverse drug reaction. We are going to discuss it later. Okay, amiodarone contain iodine in its structure, therefore may cause thyrotoxicosis. Amiodarone bioavailability between 35-65%. Amiodarone onset of action take 2 to 3 days to start working. So this means that we cannot prescribe amiodarone oral for the emergency case, because this medication starts working after 2 days. We cannot use amiodarone for emergency case. Okay, amiodarone half-life 3 to 10 days. Other component, we have several weeks, could be 100 days, the half-life. Okay, the amiodarone used for ventricular arrhythmia, atrial fibrillation, life-threatening arrhythmia in general, life-threatening arrhythmia. So we can apply for the patients from life-threatening arrhythmia, ventricular arrhythmia, and atrial arrhythmia. Side effects for amiodarone, you can see the percentage here. Pulmonary fibrosis, 3 to 17%, hyperthyroidism, 3%, hypothyroidism, 30% of patients suffer from hypothyroidism. Amiodarone may induce thyrotoxicosis, and we discussed thyrotoxicosis. It's like severe hyperthyroidism. We have another important one, maybe phenomenon to call the blue-gray skin discoloration. Blue-gray skin discoloration, and then we have hepatitis, phlebitis, and heart block. We have some images here. You can see the pulmonary fibrosis, the blue-gray skin discoloration, and we have the corneal arcus, and then we have the medication's name, could be available injection or oral as tablets. Amiodarone. So we need to remember what is amiodarone, mechanism of action. You can see it's like potassium, sodium, calcium, beta blocker, and it has beta blocker activity and cause vasodilation. This medication associated with the side effects such as pulmonary fibrosis, hypothyroidism, blue-gray skin discoloration, and corneal arcus. Okay, then they tried to develop a new medication derived from amiodarone. We call this one dronedarone, non-iodination, less side effects, shorter half-life, but less effective than amiodarone. We have dronedarone, less effective, less side effect. Okay, moving to the third one, we have sotalol. Sotalol, non-selective beta blocker. That means sotalol block beta 1 and beta 2 receptor. So sotalol, non-selective, block beta 1, beta 2, in addition to blocking potassium channel. So the question here, which of the following beta blocker belong to the class 3 cardiac arrhythmia? So we have sotalol. Please remember that. This medication, the same, used for atrial fibrillation, atrial flutter, and ventricular arrhythmias. Okay, the last two medication belong to the class 3. We talk about potassium channel here. Class 3, we have the first one, abutolide prescribed IV for emergency, for the acute, when the patient come to the emergency room, suffer from atrial flutter or atrial fibrillation. When you prescribe this medication helps to convert the atrial fibrillation, atrial flutter to the normal sinus rhythm. So the patient come to the clinic, we prescribe abutolide for as acute treatment for acute conversion of atrial flutter fibrillation to the normal rhythm. When the patient discharged from the hospital, we place the patient on the oral capsule dofetilide, and dofetilide maintain the normal rhythm for the patient. So now we have approach. Patients suffer from atrial flutter, atrial fibrillation, we prescribe butylide in the emergency room. When the patient discharged from the hospital, we move the patient to the oral medication, dofetilide. You can see the oral medication and the injectable medication here. Okay, class 4, we have calcium channel blockers. Here we need to remember we have another group of medication. It's not only these two drugs belong to the calcium channel. We have amlodipine, for example, here. And when we have nifedipine. But this two medication is not it's not allowed to use it in patients suffering from cardiac arrhythmia. So this two medication is not in we cannot use this two medication in the cardiac arrhythmia. Two medication belong to the calcium blocker, could be used safely in patients with cardiac arrhythmia, we have verapamil and diltiazem. Please remember, verapamil, diltiazem, the only medication belong to the calcium channel blocker and used in patients suffer from supraventricular tachyarrhythmia. Anything above the ventricular, such as AV node or SA node, we can use this medication. Supraventricular to consider like major indication for use of verapamil. Diltiazem has similar action. So for class 4, we have calcium channel blocker, verapamil, diltiazem, and here we try to remind us, they said verapamil showed a greater action on the heart more than activity on the smooth muscle cells. So the main side of action for verapamil will be the heart. Here we need you to maybe to remember something. Verapamil, okay, block calcium channel in the heart, decrease heart contractility and decrease heart rate. So negative effect on the heart. Verapamil has negative effect on the heart. So mainly affect the heart. You can see it here. Diltiazem has intermediate action on the heart. Okay, moving to the last group of medication used as antiarrhythmic agents, what we have here, we have the miscellaneous agents such as digoxin, adenosine, and magnesium sulfate. So we are going to discuss that, but speaking about magnesium sulfate, we use it IV for emergency for patients suffer from cardiac arrhythmia due to the digitalis or digoxin toxicity. Digoxin toxicity, if the patient suffers from toxicity due to the, okay, so magnesium sulfate will be the drug of choice, and this prescribed IV. Adenosine, we have it in the next slide, and they said digoxin used to control atrial fibrillation and atrial flutter. How this medication work? Digoxin blocks sodium potassium ATPase. So this one here, if you need to understand the mechanism of action of digoxin, I refer you to the lecture already published on heart failure, and we covered the digoxin mechanism of action in details in that lecture. Okay, speaking about adenosine. Adenosine, first of all, we need to remember the adenosine. It's like you can have it here. Adenosine injection, IV. That's number one. Adenosine used for acute, anything IV. Remember, when you have IV, remember the acute treatment, emergency treatment. So for acute supraventricular tachycardia, okay. Extremely adenosine has extreme short half-life, 10-15 seconds, due to the rapid uptake by the erythrocyte endothelial cells. Adenosine has a very low toxicity. So if you remember, if you go back, we have some medication to consider like wide. Some medication considered like wide. Let me clean this one here. Some medication we have wide therapeutic window. Other medication considered like narrow therapeutic window. Okay, digoxin belongs to the digitalis group, inhibits sodium potassium ATPase, increase intracellular calcium and sodium in the cells, increases vagal or acetylcholine activity, increase heart contraction. This digoxin used for patients suffering from atrial fibrillation or atrial flutter. Medication could be prescribed. We have it oral. We have digoxin IV, digoxin narrow therapeutic window. So from our lecture here, you remember we have some medication considered like wide therapeutic window, such as adenosine, such as lidocaine, and we have other medication considered like narrow therapeutic window, such as digoxin and miscellaneous. Okay. We're done with the cardiac antiarrhythmic drugs, but this slide here summarizes information for us. For example, for 1A, we need to remember we have 3 medication: procainamide, disopramide, quinidine. Class 1B, we have lidocaine, mexiletine. Then we have flecainide, propafenone. Also, it's not in the list. For beta blocker, then we have potassium blocker, butylide, sotalol, verapamil, and adenosine for And here, if you look on the amiodarone, for example, here it's the most important medication in prolonged QT interval. For example, if you look how many arrow we have there. Okay, so moving to the we have done with the cardiac antiarrhythmic drugs. Okay, so at the end of this lecture, I would like to summarize what we already discussed in this brief lecture about antiarrhythmic drugs. We covered the conducting system, we spoke about normal sinus rhythm, and we explained the cardiac action potential. Then we moved on the most popular causes of cardiac arrhythmia. Then we explained the category of or classification of antiarrhythmic drugs. We spoke about the mechanism of action, how the medication work, the clinical use of medication for atrial arrhythmias or atrial flutter or atrial fibrillation, ventricular fibrillation or ventricular tachyarrhythmia. We cover adverse reaction. We mentioned the anticholinergic, alpha blockers. We spoke about synchronism, for example. We mentioned lupus syndrome, and we mentioned all these side effects associated with the blue and the gray skin discoloration associated with the amiodarone. So we need you to remember all these maybe characteristic of this medication. Briefly, if you need more details, you can find it in the textbook available on the Access Pharmacy or medical textbook, or you can find it on the medical journal. At the end of this lecture, thanks so much, everyone, and have a great day. And I wish you the best in your career and success.